first and foremost, Dr. Ghia, thank you for taking the time to speak with us today. I'm a hematologist practicing in the community just north of Toronto at a cancer center, and I have a large malignant hematology population. I've seen you speak many times, and so again, thanks for speaking to us today. And our focus today is around the COVID issues and how it's affecting CLL therapy. And Italy has been ahead of the curves, whether you wanted to or not, in this whole issue. And so what we want to try to get from you today, Dr. Ghia, is some insights into your experience with COVID with a focus on CLL patients. Just so you know where we are in Canada, we just had 111 cases in our province, or only 250 in the whole country. So we're doing pretty well as well in terms of flattening the curve. I know Italy's done very well as well. So maybe I'm going to ask you a very broad question to start. You've seen them, but tell us how you changed your CLL therapy through COVID and where you've ended up in terms of how your approach to CLL. It's a very broad question, and I'll stop there and follow up later.
Yes, in general, thank you. Thank you for the invitation, for the question. Actually, in terms of management, what we changed, and that was probably the first change we applied, even before we really realized the entity of the crisis, was really to ask the patient to stay at home. And so we canceled our outpatient clinics appointment, and we recommended the patient to stay home, because based on the assumption that patient with cancer in general, with CLL in particular, due to the immunodeficiency and so on and so forth, we thought that they could have been at higher risk of getting the infection. So we didn't want them to expose them. And indeed, at that time, the hospital was indeed a place where people, even the doctor, the nurses, could be more easily infected. At that time, you have to think we had hundreds of people, symptomatic people, coming to the emergency room. So it was really a dramatic situation. So probably due to that, I have to say that in general, now that we look after probably 6 months, 5-6 months after the beginning of the crisis, a minority of our patients indeed had the infection, and a minority had symptoms and were hospitalized. So maybe it was because of the strategy, maybe because in general, patients with CLL, like with other hematological disorders, they are already aware of the risk of infection, so they have a distinct behavior. They sometimes wear masks even in regular life, even independent of COVID-19. So for all these reasons, I think that we have to say that definitely a good measure is to be cautious, to avoid too many entries in the hospital, in the clinics, and definitely we change it completely the way how we follow up our patient, how we visit our patient. So we implemented telemedicine services, we delayed the controls, we learned even more that our patients don't need to do and repeat the test too often. We don't learn so much at the end. The disease is indolent, is chronic, so it takes time before you can see meaningful changes. So probably this crisis helped us really to understand again what's the best management of our patient, which means not too many things, not too many tests, not too many visits.
Yeah. Can you tell me, as you're coming out the back end of COVID, we're all doing things differently now. Can you tell me now how you think about treatment regimens and CLL? Is that part of your treatment decision making? We can talk about upfront or relapse therapy, but in terms of, are you thinking about what's best for your patient, and you bring in the COVID issue? You're controlling it now. Is COVID affecting your therapeutic decision making about what drugs to choose, including finite versus continuous therapy, those kind of things?
Yes, indeed, COVID, again, we have always to see the bright side of things, and COVID taught us, helped us to move probably far from chemoimmunotherapy. And so in Italy, the situation, availability of drugs is still not equal for everyone, because, for example, the BTK inhibitors, ibrutinib, is not reimbursed for every patient, but only for those elderly above 65 years of age, for example. So we really understood during this period how much benefit would be for a patient to have available an oral drug instead of having the necessity to come in for infusion for a chemoimmunotherapy. So we started a number of activities in order to have the possibility also to prescribe, have these drugs reimbursed also for the young patients, which are still not completely implemented, but really thinking that this situation really helped us to understand the value of an oral drug, very effective, like most of our novel drugs, compared to chemoimmunotherapy. And the continuous treatment versus time-limited treatment is not an issue, because we really thought that it was more relevant to have an oral drug that kept the patient far from the hospital and could be self-administered, like ibrutinib, but also venetoclax, so all the novel inhibitors, rather than really the length of treatment, which is really not doesn't have a real meaning in this situation with the COVID-19 crisis.
Tell me about how you're thinking about monoclonal antibody therapy with targeted therapy, rituximab, obinutuzumab. How are you thinking about those drugs going forward combined with the targeted agents? Have you changed your thinking about giving venetoclax with rituximab, or now that things are under control, it's okay for the patient to come in for 6 doses of rituximab? I'm curious in your thoughts.
That indeed, from a practical point of view, the biggest change has been indeed in the use of monoclonal antibodies for both in the case of immunochemotherapy, but also, as you mentioned, together with venetoclax. So during that period, we skipped, probably we tend to skip the monoclonal antibody and to delay the infusion, to wait for better times. Again, in the assumption, we know also very well that anti-CD20 antibody, of course, are very effective in depleting also normal B cells, so possible an immune reaction, an immune response. And so based on that assumption, we all thought that monoclonal antibodies maybe could be delayed to better times. And indeed, this became also part of a recommendation that we wrote together with other distinguished colleagues from the US and from Europe, where we indeed, the only major change in the treatment was really a postponement of the monoclonal antibodies.
Now that Italy and Canada's following is getting better control of COVID, your numbers are down. Are you starting to get back to how you would normally prescribe monoclonal antibodies for CLL, or depending on local incidence and control?
Yes, I think, and it was also a kind of general agreement among so-called experts, meaning that maybe what we learn is that we have to modulate our behavior and the management according to the waves of the infection. So in this very moment, I have to say that the situation in Italy is definitely under control. Also at our hospital, we reopen fully our outpatient clinic, and there is no more major measures except the control of temperature while entering the hospital, and wearing the mask, but this is still mandatory everywhere, yes. Even outside, not only inside the buildings, but outside the buildings. So beside this, all the rest of life is normal. So patients are coming back, and we schedule a regular appointment. What changed again, but this is again a benefit for patients, is that we don't have any more crowds of patients in our outpatient clinic. So everybody comes exactly on time at the appointment. you confirm the day before. Now there is a service confirming the appointment with the patient exactly at that time. If he or she doesn't come, then she is cancelled. If it is confirmed, then the relative waits outside. He comes in for 15, 20 minutes, 30 minutes, and then he goes out with no crowd, nobody waiting in the waiting room. So everything really tiny and clean. So this is again an advantage and for patients. So having said that, all the rest is now back to normal. So when we plan to do immunochemotherapy or an antibody infusion, we do it as we were doing before.
It's interesting. I'm nodding, Dr. Ghia, because we're doing the same. There's no crowds anymore, which is a nice thing when you look out in the waiting room, and we're limiting visitors, those kinds of things. So I'm nodding just because we've been following suit as well. Tell me then, in terms of virtual care and your CLL patients, how are you using virtual care? Are you going 3 months, 6 months, or I guess you're figuring it out, but how are you currently using virtual care for your CLL patients?
I have to say again that the COVID-19 crisis helped us to move very quickly to virtual care. It was something that we've been discussing for years about it, and it was always impossible to do it for administrative reasons, privacy reasons, whatever reason. From in one day, I would say in 1 week, it has been implemented by my hospital, and I started advertising it among the patients. And actually, I have to say that many picked it up, and regardless the age of the patient, because you may say patients with CLL are elderly, they are not so confident with computers. Not true. It's really independent of age. And many really welcome it because I have also many patients coming from all over Italy. So that really helped because, of course, there is also a saving in terms of time and travel and so on and so forth. So I think this again is a change that will remain. And patients had a very positive experience. And in terms of clinical management, I have to say that the only issue I had was the physical exam. Of course, you cannot palpate the lymph node or the spleen, and you cannot get the feeling of how the patient is doing. So I replace it, I have to say, with ultrasounds. So I found it. So now I ask a patient to have a full body ultrasound. So like if they have their lymph node in the cervical zone or axillary zone, then I ask them, please do an ultrasound so I can check and see how it is going. And beside that, all the rest remains very, very similar to what is happening in real life. So you check the test, you talk to your patient, and they see your face. So you can. I felt really very. I really didn't have much of a trouble of interacting with my patient through the video. And I have to say that also they had a very good feeling. I had even new consultation, secondary opinion coming in with this system. They didn't know me, I didn't know them, but everything really worked out very positively.
How are you using COVID testing in your CLL patients? Are you testing all of them that you see before treatment? Curious how you're using COVID testing.
Absolutely. Of course, we tested and we test now everyone who has symptoms. And at the beginning was respiratory symptoms. Now everything can be associated to COVID-19. So at the end, probably we are testing everyone. Definitely, there is a policy which is mandatory then to test every patient who comes to the hospital for a therapy. He has to be tested for the SARS-CoV-2 virus. So this is implemented and mandatory. Everyone who is hospitalized, even for an elective surgery or anything, they have to be tested. So this is the policy. We are launching a project to test by serology all patients with CLL in order to see really the prevalence of the infection, because as I said, at the end we had really a handful of patients, like probably only 10 patients in total in my hospital with CLL who had symptoms and were hospitalized or not. So which I'm impressed, out of a 500 patient, a cohort of 500 patients. So it's definitely low numbers.
Any recognizing the low numbers, any comments on therapy of CLL patients who are COVID-19 positive?
So this is a long debate, meaning that, as I said, we wrote together with other colleagues the frequently asked questions that are available on the ASH website and that are also endorsed by EHA. And we have been updating them throughout the crisis. And the last update was actually in June. And the only thing that changed throughout 3 or 4 months of follow-up, let's call it, was indeed that we are mentioning now that when patients are on a BTK inhibitor, maybe we don't stop immediately the treatment, especially if the symptoms are mild, because of this idea and hypothesis that indeed BTK inhibition could be beneficial against the cytokine storm, the inflammation, the hyperinflammation, which is actually the reason of severe COVID-19. So this is, as you know, now there are no solid data. There are prospective studies that started testing BTK inhibitors in patients with COVID-19, regardless B-cell malignancies. So we will know the answer. With in a retrospective series that we studied at European level of patients with CLL and COVID-19, again, it seems that those who were on BTK inhibitors, somehow they had a milder COVID-19, though when it became severe, it was not BTK, being on BTK inhibitors or not, it didn't make a difference. So it really seemed that it could protect in the initial phase of the disease. This is, of course, all anecdotal, retrospective results. So, but in general, that's the feeling, the idea that changed in the past 3 or 4 months. So maybe we would be more cautious to stop the treatment in case the patient turns out to have COVID-19 and is still on BTK inhibitors.
Does your use of IVIG, has it changed at all in this population?
Well, that's a question, and especially from the US colleagues also came. I have to say that my use of immunoglobulin is very, very limited. But the recommendation that we gave, again, if that was a reason to come to the hospital, maybe it's better to delay the immunoglobulin infusion or to move to subcutaneous infusion so that one could be taught and do it at home. But in general, one thing that is always good to say that don't start immunoglobulin because of the COVID-19, meaning that it's not protective against the SARS-CoV-2. There are no immunoglobulins in the preparation that can protect from the infection.
I think the Canadian CLL experience in the COVID era reflects what's going on in Italy now as well, in terms of more virtual visits, less interactions with the actual cancer center or hospital, and trying to be leaner and less patient contact points. Dr. Ghia, it was a pleasure again. I've seen you speak. So next time, when we ever get to in-person meetings again, I'll run up to the podium and say hello, and even we might be able to shake hands again. We'll see.
maybe.
Okay.
Not really sure when.
But sincere thanks for taking the time. We appreciate it. You guys have been leaders.
Thank you very much for inviting.